Hello everybody, this is me, Dr. Sergio Rovinski from Shoulder Planet, here from São Paulo, Brazil. I am very honored to be participating here from Wiroc, this lovely meeting organized by BOSS, Bombay Orthopaedic Society, and I invite you to see all of the videos that I have sent to this wonderful meeting and to learn the most you can with them. And if you have any doubt, don't hesitate in sending me an email. My email is sergio@shoulderplanet.com.br. I thank all of the organization of this lovely meeting, and I hope you have fun seeing all my videos, and Dhanyavad. Hello my friends, this is Dr. Sergio Rovinski, orthopedic surgeon, shoulder and elbow surgeon from São Paulo, Brazil. And in this video, I am presenting a case that represents a classical situation that now and then we may face in our daily shoulder practice, which is an arthroscopic rotator cuff repair that evolves post-operatively to a hard and difficult to treat frozen shoulder scenario. As we all know, many arthroscopic cuff repairs in fact can develop some stiffness, and many do, post-operatively. But the vast majority of these cases can be treated non-operatively. Anyway, some cases can be really hard plastia. So post-operatively, this patient evolved with a frozen shoulder scenario that was really hard to manage. And 18 months after that surgery, what means 1.5 years after that surgery, the patient had gained almost full internal rotation and a reasonable forward flexion in the left shoulder. But nevertheless, she also developed a considerable limitation of her external rotation on her left shoulder, in a way that she had nothing but 0 degrees of external rotation in the left arm and in the left shoulder, what was really bothering her and impeding her of doing her daily and usual activities. So an arthroscopic capsular release was indicated by me, and we did this surgery in 27 December 2017. And the intention here, as she fundamentally didn't have external rotation, was to do an anterior capsular release. So this is the patient just before surgery, in which we can see here that she had a reasonable elevation of the shoulder, but the main problem of hers was the big lack of external rotation. So as we have seen here, she had 0 degrees of external rotation. Now we are seeing this short video again, and that lack of external rotation was really bothering the patient. So now we are seeing it again. So as we examined her under anesthesia, she had really no external able to start the surgery with a soft tissue shaver. So now we're starting this surgery with a soft tissue shaver in the very anterior part of the anterior capsule. And just as we started the surgery, it was very easy for us to see and to identify the intra-articular long head of the biceps tenodesis that we had done 18 months before in the lesser, with a metallic anchor in the lesser tuberosity of this left shoulder. So as we started the surgery, as we are seeing now pointed by the two yellow arrows, we are seeing here the suture that we used in order to do the long head of the biceps tenodesis in the lesser tuberosity. And once we had found it, we would have nothing to do but obviously not to touch it and just continue with the surgery itself. So here we are with the shaver on the inferior part of the anterior capsule, just above the subscap. And it's not easy to start the surgery because of lack of space. Here we are debriding the synovitis on the very anchor of the long head of the biceps, from which we had done the tenotomy some 18 months before. And now this is a very important image, and I think that this is something that the orthopedic surgeon must really understand. So what are we seeing here in this photo? And I consider this photo a very pedagogical one. So what we are seeing here is in the very inferior part of the video, the upper part of the subscap, which is now being pointed by two yellow arrows. And on the upper part of the video, what we are seeing here is the anterior capsule, which was the pathological tissue encased in this very surgery, and removing it was the very intention of the surgical procedure. So what we did here was to create an entrance, a hole between the very inferior part of the thick and pathological anterior capsule and the very superior part of the upper subscapularis. So then we continued with the surgery, entering here with an artery forceps to enlarge this hole, to make it larger and to make the entrance of other instruments easier. Here we are using again a straight artery forceps, not a curved one. And the next instrument we used it, so it was an electrocautery device, just to diminish the super thick anterior capsule. This is what we are doing now. And just after that, we entered with a very important instrument in this kind of surgery, which is the arthroscopic scissor. So with an arthroscopic scissor, we are now cutting from inferior to superior the very thick and altered anterior capsule until we started to see all the anterior deltoid muscle belly again. So now we are doing it from inferior to superior, and now we are using the shaver just to enlarge all of this removal that we started to do with electrocautery and the arthroscopic scissor. Now we are doing something that I consider very important, which is to cauterize every very bleeding artery on the region, because we don't want much bleeding here in order to avoid the creation of new fibrotic tissue and hence new adherences in this shoulder. So here we are cauterizing the anterior labrum, and this is again an image that I, Dr. Sergio Rovinsky, consider very pedagogical, and this is why I am showing this photo to you in this video. So now we are seeing a photo here which I consider very important, and we must understand in terms of arthroscopy which are the anatomical structures that we are seeing here in this very image. So on the left part of this image, of this photo, we are seeing the very medial part of the humeral head. On the very inferior part of this photo, what we are seeing is the upper part of the subscap, considering that the insertion is on the left part of the photo, where the subscap is inserting in the humeral head. On the right side of this photo, what we are seeing here is the anterior labrum, and just in continuity with it is the articular part of the glenoid, of course. And when we look to the front, we see an U-shaped image. And what is this? So this U-shaped image corresponds fundamentally to the removal of the altered, thick, and pathological anterior capsule, and this is fundamentally what this surgery is about. And so who is this red structure that we are seeing here with all of these arrows? This is the muscle belly of the anterior deltoid, and we were not seeing it because we had so much pathological tissue that we remove it. And again, this is what the surgery is about. So continuing with the surgery now, we entered with the shaver to remove all of the adherences between the subscap and the inferior part of the glenoid. This is what we are doing now. It's very important not to create an iatrogenic Bankart lesion. Okay, we must not cut the anteroinferior glenohumeral ligament, but just remove, as we are doing here, all the adherences between the glenoid and the subscap. And now we are seeing here basically the upper part of the subscap, and here the surgery has gained, the patient has gained full range of motion. Again, full external rotation. We are internally and externally rotating the shoulder, and the motion was back again. Finally, we decided to do some ablation of the superior fibers of the subscap, because we think that this is worth doing. We do ablation of the superior fibers of the subscap in low temperature, because we don't want the subscap to develop, because of this fraying, any kind of tear in the future. So now we are just ablating the subscap, the superior part of the upper third of the subscap. We are basically finishing it now. It's finished, and this is the final view in which we can see the ablation of the subscap and the removal of all the anterior capsule, and at this moment the surgery was then finished. So this is the final result. In the very end of this surgery, the patient had gained full external rotation again. This is what she really needed, and not only her external rotation was fully recovered, but in the very end of the surgery, her forward elevation was quite better, and at that moment the surgery was then finished.